It is my great honor to be here as interactions between our members, between KSIR and TSIR have grown. It is natural that this kind of joint session would take place. I would like to give special thanks to our colleagues from TSIR for inviting us. Thank you. Now I'm talking about various tips in urologic IR. Maybe it will take 15 minutes. It is, how can I see the, you don't see, can I make it seen here? Oh, no, I mean this indicator, no? No? Okay, not easy. Okay, not easy to show the indicator. Okay. This is a case showing importance of puncture location for ureteral intervention. With this lower pole puncture, guide wire insertion, it is stiff guide wire, cannot negotiate through the ureter. So change the puncture for the guide wire to be more straight, and it was successful then. How about this? Puncture was done, PCI was done through lower pole calyx. Only PCI is possible, but for ureteral intervention, it is a kind of a U-turn course, 180 degree. So with use of a Balkin sheath, I did a balloon dilation, was successful. But over the guide wire, insertion of a double J stent failed. So it shows importance of puncture for the guide wire to be more straight. In this case, similar, lower pole puncture. So I don't like lower pole puncture because for potential ureteral intervention, it is very disadvantageous. So guide wire insertion was impossible, and I changed the puncture through the mid-pole, and guide wire insertion was successful. As you can see here, another puncture. Don't be afraid of doing another puncture and then balloon dilation, but it was not complete, so cutting balloon dilation was done. So very tortuous ureter like this by urologist, it was failed, and this was not overcome, this curvature, so it was also failed by interventional doctor through PCN. It cannot pull. Please remove the. I have to record the image. Remove the mark indicator. Okay. So after inserting guide wire and with jerk, pulling the guide wire frequently, straightening the guide wire like this. And this is a kidney transplantation stage, so adhesion, so very tortuous, and it is fixed. In the case, the kind of a jerk, pulling with jerk is not done frequently. So in the case, I insert the balloon as distal as possible, and then balloon dilation, then it provides support. Then just pulling the balloon catheter, it will straighten the course. Then double-J stent insertion was possible. Negotiation of the occluded segment is very tricky in sometimes. This breast cancer patient with UVJ obstruction, I used Balkin to give support, and then by steep guide wire and 5-French catheter, not successful, and guide wire kinking like this. As a final resort, I used the steep end of guide wire, and it should be toward the bladder. So in the case, bladder filling with some diluted contrast is helpful. Anyway, it puncture toward the bladder with a steep end of the guide wire, then change with a soft end like this, and successfully we can see the looping of the guide wire, it is into the bladder. Then balloon dilation and double-J stent was followed. In this case, initial attempts with steep guide wire, micro 0.025 guide wire failed. Balkin-Schiess support also failed. So in the case, I used steep distal end of steep guide wire, puncture toward the bladder like this, and then change with a soft hand. So distal end piercing, puncturing, might create some pass, to the bladder, and then soft end of the guide wire can pass frequently. Then compi catheter could not pass 5 French, so with 4 French cobra catheter, it was successful. Then steep guide wire insertion and followed by a double-J insertion. Similar case, proximal end of 0.025 guide wire could advance further, but even 4 French could not pass over the guide wire. So in the case I used Balkin, and then the guide wire pass into the neobladder, and then 4 French catheter, then usual double-J catheter insertion was successful. So I found that Balkin-Schiess 7 or 8 French, it is long enough to reach the stenotic portion, really provides support for the guide wire or balloon catheter insertion. In this case, guide wire pass was possible, but tight stricture here, arrow, so balloon catheter cannot pass. But with help of Balkin-Schiess, balloon catheter can pass through the stricture. And this case, guide wire cannot pass to the bladder, so insert the Balkin-Schiess, then could insert the guide wire into the bladder, and then 4 mm balloon dilation was possible, then double-J insertion. So it is our report. Long Schiess like Balkin-Schiess is very useful to overcome this kind of very tortuous course. In this curvature, cannot do balloon or double-J stenting. We insert the balloon Balkin-Schiess, and then could insert the balloon successful. It is very difficult case some time ago, or young female patient, you can see here, very strong fibromatosis below the right kidney, in front of the right kidney. It is, it seems like pancreas, but not pancreas. It is fibromatosis in front of the right kidney. It is actually a horseshoe kidney. So the gray color here is actually fibromatosis, not pancreas. PCN was necessary because of hydronephrosis. Very tight stenosis of the proximal ureter. So 4 French, 5 French impossible, only micro caster and guide wire with difficulty, but successfully into the very tortuous course into the bladder. But over the micro guide wire, impossible to insert any 4 French or 5 French catheter. So I thought through and through technique, catch at the bladder side can work, and a patient position change into supine position from prone position, and through the urethra, the distal portion of the inserted guide wire was cut, and it is through and through technique, but it's too tight to permit the 4 French caster easily. Anyway, 4 French caster permit was advanced, and 0.035 inch slip guide wire was inserted. But 4 millimeter balloon caster cannot pass. So through Balkin-Swiss, 4 millimeter passed, and then 6 millimeter, 8 millimeter, and finally WJ stent insertion was successful. You can see here. WJ is piece is here, and then WJ is starting from here, and this is traversing the fibromatosis and into the bladder. You can see here, good function. So it is a summary of my experience for tips of negotiation of tight urethral obstruction. Basic, I usually slip guide wire using 4 French or 5 French compicaster, and support with Balkin-Swiss is also another tool. And alternative wires like smaller guide wire or micro caster and wire is useful when contrast passage is very small but anyway visible. Microcaster and wire insertion is useful. As an advanced technique, back end of 2.5 or 3.5 guide wire is helpful. Not always successful, but try to puncture toward the bladder. So filling the bladder with dilute contrast is sometimes helpful. And then slip end of 3.5 inch guide wire follows. Sometimes through and through technique can be utilized. Clock caster is not easy to change. In the case guide wire insertion impossible. In the case I retract as much as possible and made a hole here, and then insert the hole to be located within the renal pelvis and insert the guide wire through the pelvis. And then remove the catheter and insert the new catheter as you have seen here. Skip. The made hole is into the renal pelvis again, and insert the guide wire and remove the old catheter, and then new catheter insertion follows. It is the last concept for vascular case. This patient, the history is very important. Pumping hemorrhage during WJ stent removal, WJ stent changed by urologist is very characteristic history. And like this, cervical cancer, and then long history of radiation and long history of WJ stent. This patient, 7 years of WJ stent change frequently. Hemorrhage during WJ stent removal by urologist. So we searched at first renal origin, but kidney normal. And I did iliac angiography, and you can see here very small pseudoangiogram-like structure. So I thought there is no branch like this causing pseudoangiogram here. But anyway, I try to select this. It is not artifact, but contrast agent. And then select, and contrast injection shows, you can see here, some contrast column vertically, and I found that it is a dilated ureter and contrast into the ureter. So it is arteriourethral fistula case, and then immediately stent graft insertion was done to occlude the fistula. Unfortunately, this patient developed some problem related to stent 8 months later, maybe because of previous radiation history. So the artery is fragile to this kind of trauma by stent, and pseudoaneurysm was developed. So the surgery was done, and then the patient is stable at this time. This patient, radical cystectomy and neobladder, and you can see here double J. Double J is very close to the iliac artery here, and then similar history, but the frequent hemorrhage from the bladder is noticed. Angiogram for kidney normal. A second angiogram also shows no active bleeding, but prophylactic embolization. At the time, the bleeding source was anyway related to PCN. So after removing the PCN, only guide wire kept like this, like we do in PTBD bleeding, but no bleeding anyway. The track, the artery close to the PCN track was embolized with gel foam. And then I tried to change remove the hematoma in the collecting system, and I found that some blood is coming from the below, and then so the bleeding source could be lower portion, and then I inject contrast. You can see here, contrast is to the iliac artery, so it is detected by urethral side. And angiography immediately shows no fistula. It is actually normal. So I found that this kind of fistula can be discovered only by a urethral side. And anyway, standing up insertion, and the result was happy. And I did the aspiration with the Hofmann sheath. It is useful to aspirate the hematoma in the collecting system. It is a recent case just several weeks ago. This patient also requested for renal angiography, cervical cancer, and then also there is double J stent for a long time. And renal, I did radial approach with the patient is lying prone position with a concomitant kidney intervention, for example, PCN removal or with only guide wire keeping, and then no bleeding at all. And I also did embolization with quick soluble. It is less harmful with even guide wire or only guide wire kept, but no bleeding. And anyway, some embolization was done like this. And then I tried to insert the PCN again and found out the hematoma is, big hematoma is from below. And you can see here, very interesting. And I suspected this kind of arterial urethral fistula and then injected contrast agent. You can see here some movement in the here, contrast here like this. So I saw it is like pumping from the arterial side. And then you can see here contrast agent, very like this. This is a ureter right side. Contrast injection shows, although some faint, but it is definitely iliac artery. And then here angiography shows, you can see, small or pseudoaneurysm here on magnified view. And internal iliac artery origin was close, so it was embolized with a plug, and stent graft cobera deployed. So high risk group, we have to know the history, long-term indwelling double stent, and pulsatile bleeding during stent exchange is historic, very typical. And iliac angiography should be first, but there's no definite fistula. Urethral side, we have to check. And then stent graft insertion is the treatment tool, and outcome is usually good. Thank you for your attention.